Hello, everybody, and a welcome to the Parkinson's Academy webinar. This afternoon, we will be exploring the treatment and management of Parkinson's disease dementia and Lewy body dementia. If you have any questions for the panel, please use the Q&A function. So with no further ado, let's get this started with our first speaker, Dr. Tim Rittman. Over to you, Tim.
Hi. Thanks for the introduction to talk today. It's really exciting, and I think this is a really important topic. So what I'm going to do is sort of introduce you to a bit of the sort of diagnosis of dementia with Lewy bodies and talk about the sort of concept of Parkinson's disease dementia. And then Alison, who's is going to talk a bit more about sort of management of those disorders. So my name's Tim Rittman. I'm a neurologist in the cognitive clinics at Addenbrooke's Hospital in Cambridge, and a senior clinical research associate at the University of Cambridge. So we'll go through a few of the clues and sort of biomarkers for dementia with Lewy bodies. I'm going to spend a bit of time about sort of how we diagnose that and tips of the trade which might be useful to you, and then talk a bit about sort of differential diagnosis and some aspects of cognitive dysfunction in Parkinson's disease. So, dementia with Lewy bodies. I think it's really important to get this diagnosis right, because it is one of those conditions which is both underdiagnosed and overdiagnosed. And it is an aggressive disease compared to, say, Alzheimer's disease. And the prognosis is a good few years shorter. And it does come with complex motor and cognitive features. And some of the treatments for some symptoms will exacerbate other symptoms. So it can be a very difficult disease to manage. So it is important to be accurate. And I just want to sort of flag up a few things where I think people fall into traps of jumping to a DLB diagnosis a bit too quickly. So Parkinsonism with dementia is not dementia with Lewy bodies. So many people with Alzheimer's disease, for example, get Parkinsonism particularly later on in the disease. If people have delusions and hallucinations and have a dementia, that's not automatically dementia with Lewy bodies. Again, in vascular dementia or Alzheimer's disease or other types of dementia, you can have delusions and hallucinations. Parkinson's disease with hallucinations on its own is not dementia with Lewy bodies. And that's certainly a trap I've fallen into in the past. So you can learn from my errors there. So let's go through and try and see if we can pick out a few things which are a bit more specific to Lewy body dementia. So let's start with a case study. And I've left this sort of deliberately vague, really. It's the sort of person who you might be asked to see or evaluate. And some of the features of this history might push you towards thinking about dementia with Lewy bodies, but they're not. It's not diagnostic from this case on its own. So some suspicions and delusions. There's perhaps some hallucinations. So making 3 cups of tea for 2 people, and this sort of aggression and perhaps delusions at night, seeing people outside the house. Could this be Lewy body dementia? So I'm going to flash up the sort of McKeith criteria, mainly for sort of reference for going back to the slides later on. And we'll go through some of what I think are the most important clinical features on here. I'm not going to talk too much about REM sleep behavioural disorder, but if you can elicit that as a feature from the history, that's very helpful. So let's go through a couple of other bits and pieces. So firstly, hallucinations. And the hallucinations in dementia with Lewy bodies are very characteristic. And if your patient doesn't have these very characteristic hallucinations, then you might think twice about the diagnosis. So for example, if they're telling you they're seeing animals or spiders running up the wall, that's not a typical DLB-like hallucination. So it might just flag up to you that something else might be going on. So they're typically describe people, and these people are still and silent. Sometimes they're family members or people they know, but often not. And they're typically not frightening. Not always. Sometimes they can be scary, but typically the hallucinations are not scary. What we often see is people start with misperception. So they might see a curtain and think it's a person, and then over time the hallucinations become more fully formed. I wouldn't necessarily treat hallucinations on their own unless they're causing distress or problems. But Alison will, I'm sure, will touch on that in a bit more detail later on. There is a bit of literature out there trying to understand where these hallucinations come from. And this is a nice paper from John Suckling's lab where they can compare psychiatric and neurodegenerative hallucinations. And in the neurodegenerative group, there's a sort of network of occipital and parietal regions which are involved, and some of the sort of limbic regions as well. So that's hallucinations. What else we look for? We look for fluctuations. So we all have good days and bad days, of course, but these are sort of massive changes. So the relatives might say, well, on some days, I'm not sure actually whether there's anything wrong with him. And it seems completely normal, back to how he was. On other days, no, he can't do anything at all. It really has no function. So there's a massive fluctuation from day to day. The fluctuations can be on a sort of shorter time scale, but typically it's sort of day to day. And of course, Parkinsonism. So this is the sort of Parkinsonism that you see in idiopathic Parkinson's disease. So it's upper limb Parkinsonism, not the sort of lower limb Parkinsonism you get in vascular dementia. And it's, I've put unilateral there. I suspect actually it's often a bit more often bilateral in DLB than idiopathic Parkinson's disease. I haven't got any evidence to back that up, but that's my impression. There's bradykinesia, so there's small, slow finger taps, but importantly, there's decrement with that as well, so the finger taps get smaller. And that's accompanied by rigidity. But often this is mild or sometimes even absent. So it's helpful if this mild Parkinsonism is there, but it's not absolutely crucial for the diagnosis. And often it doesn't need treating as well. So we're not really going to touch that much on treating the Parkinson's side of DLB, because firstly, I try not to, partly because they don't need it, and partly because it can exacerbate hallucinations, and sometimes, particularly later in the disease, worsen cognitive impairment as well. So next thing I want to sort of introduce really is this idea that there is a specific cognitive pattern that you see in dementia with Lewy bodies, which is distinct and separate from something like Alzheimer's disease, for example. And this is really helpful to in the differential diagnosis. There are some papers showing that in Alzheimer's disease, in pathology-proven Alzheimer's disease, where there are delusions and hallucinations, there's about a 20% misdiagnosis rate of dementia with Lewy bodies. So I think this is one area where it can be helpful to distinguish those two disorders. So firstly, people with Alzheimer's disease, they have loss of episodic memory. They don't remember events, and they have loss of working memory. Whereas patients with dementia with Lewy bodies tend to have impaired attention. So that affects their memory in a different way. So for example, if you're doing the Adam-Brooks cognitive examination and you get them to remember the name and address, the Alzheimer's patients will repeat the name and address to you at the beginning, and then they'll have forgotten it by the end of the test. In dementia with Lewy bodies, they'll really struggle to remember those 7 items at the beginning, to repeat them back to you. So they may only repeat back to you 4 out of the 7 items, but those 4 out of 7 they'll remember at the end of the test. So it's that sort of specific problem with registration more than with sort of remembering as such. In Alzheimer's disease, there may or may not be visual spatial impairment. It's helpful if there is, but it's not always there. But in dementia with Lewy bodies, if there isn't visual spatial impairment, again, it's a red flag that this may not be the correct diagnosis. So you really would want to see visual spatial impairment, and particularly on the sort of interlocking pentagons is a very helpful test. And language is different. So in Alzheimer's disease, there's this sort of stuttery, logopenic, anomic aphasia that a lot of patients have. Whereas in dementia with Lewy bodies, you can listen out to that sort of quiet voice of Parkinson's disease. Can be helpful. So well, with that in mind, how would we approach this case then? So firstly, we'd be digging around in the history really to characterize those hallucinations. What do the people look like? Are they silent? Do they move? Are they scary? Are there fluctuations? Is there massive difference from day to day in cognitive and functional ability? Is there REM sleep behavioral disorder and other sort of non-motor Parkinson's features like constipation, loss of sense of smell? Of course, examine for Parkinsonism, accepting that it may be mild or even absent, and then characterize that cognitive impairment with something like the Adam-Brooks cognitive examination or the test to memory, the TIM test, looking for that impaired visuospatial function and that impaired attention, and particularly registration on the memory test. And then listen to the speech. Does it sound like Parkinson's disease or does it sound like Alzheimer's disease? So fly through some biomarkers. Time is short, but I'll try and get through as much as we can here. So MRI is not terribly helpful in dementia with Lewy bodies. It's often normal. Where it's helpful is actually if you're thinking about Alzheimer's disease and there's medial temporal lobe atrophy, or if you're thinking about frontotemporal dementia and there's frontal atrophy, that can be useful. But normally it's pretty unhelpful. There are some group level differences if you do studies, but they're fairly diffuse and not really good enough for clinical diagnosis. You can, of course, use a DAT scan. And this is helpful, again, for distinguishing DLB from Alzheimer's disease. It won't distinguish from any other Parkinsonian disorder, but it can be helpful in that specific context of is this a Parkinsonian disorder or not? And finally, for Neuro Imaging, the FDG PET. And if you see this singular island sign, if you look on the middle row there, and you can see the cingulum with that little arrow pointing to it is preserved, but everything else around it has gone. And that's very helpful if it's present. It's not always there, so it's not terribly sensitive. Compared with Alzheimer's disease, where you lose the sort of medial temporal lobes and the parietal lobes. If you really want to be certain about the diagnosis and things are still unclear after all of those assessments, then a cardiac MIBG scan can be very helpful. In all honesty, I probably don't use this test often enough, but it's highly sensitive, highly specific. If you look at the top panel, you can see this is looking from the side. You can see the outline of the heart, and what we can see there is the sympathetic nerves. It's a adrenergic nerves. And that heart shadow has disappeared on the bottom scan. So the MIBG scan can be very helpful. And finally, in the clinical criteria, they mention polysomnography to be certain about REM sleep behavioural disorder as an indicative biomarker for dementia with Lewy bodies. So that's a sign of an alpha-synucleinopathy. So it'd be same in Parkinson's disease or multiple system atrophy. So in Parkinson's disease dementia, I just want to sort of introduce a couple of concepts really around the cognitive changes that people have. So there's really two types of cognitive change in Parkinson's disease. It's a subtle early executive change, which pretty much all patients with Parkinson's disease have if you do enough cognitive testing. Normally, it doesn't bother the patients too much, but what you do often see with Parkinson's patients, they turn up to clinic with lots of pieces of paper saying they've got all this information to give you, and then they can't really organise it terribly well and don't refer to the papers during the consultation. And that's a sort of indicative of this sort of executive dysfunction that you might see. But what people normally mean by Parkinson's disease dementia is this later posterior cortical dysfunction, so visuospatial impairment, apraxia, and impaired semantic fluency. And I'd really recommend this paper by Caroline Williams-Gray, which really characterised these two syndromes and also delves into some of the underlying genetics and genetic predispositions that make this late dementia type syndrome more likely. One of the difficult questions I find to answer for Parkinson's patients, you just diagnose someone, they're pretty well, they've got very minimal symptoms, and then they say, well, will I get dementia? I think it's hard to answer often. So you can use the interlocking pentagons as a sort of, which is an earlier sign of this late onset posterior cognitive dysfunction. But at 10 years, about 80% of people with Parkinson's disease will fulfill criteria for dementia according to DSM-3. I think this particular paper was on. So it is a difficult question to answer, but those are the sort of figures that you can discuss with patients. And then finally, very briefly, there is a few other Parkinsonian type disorders which you might come across. I saw a patient recently who had a label of possible dementia with Lewy bodies, but actually after follow-up, his hallucinations had resolved. He had no cognitive impairment at all. He did very well on the tests, and he hadn't progressed. So he actually had idiopathic Parkinson's disease. We've talked about vascular dementia being lower limb Parkinsonism, and the sort of dysexecutive syndrome. They're often, sometimes think of this as sort of grumpy old man syndrome, they're sort of dysexecutive and slightly grumpy. And of course, there'd be MRI changes for that. Multiple system atrophy, generally, not always, but usually has intact cognition and very prominent autonomic signs. So particularly erectile dysfunction in men is a very helpful symptom here, or of course nocturia and other autonomic features. And progressive supranuclear palsy has axial rigidity, so the limb examination will be normal, the balance is very poor, Sometimes you see a supranuclear gaze pulse, but that often comes later on. So I just encourage you really to try and make a positive diagnosis of dementia with Lewy bodies, looking for those core clinical features and particularly that specific cognitive profile. Think about those differential diagnoses, and where there's still uncertainty, then biomarkers can be helpful. And PDD, we sort of discussed those sort of concepts of the early frontal mild dysexecutive problem, which is usually stable, but unrelated to this later posterior cognitive sort of dementia type syndrome. So I'll finish there and hand over to Alison to take us on to the next section.
Okay, so my name's Alison Wilkinson. I'm a dementia nurse consultant working within Cambridgeshire and Peterborough NHS Foundation Trust. So I'm a mental health nurse by background, and I've been working with dementia for the last 22 years of my career. And really, again, as Tim said, these are complex people to look after in terms of whether it's people with Lewy body dementia or Parkinson's disease dementia, and often involves an awful lot of professionals trying to look after their bits of people, and sometimes that as well causes difficulties in terms of kind of management and treatment of people with this disease. So what I wanted to do today is really just kind of highlight, I thought it would be helpful to frame the symptoms and the management using the Diamond Lewy body study and the research, and I've put the link there, and it's really worth kind of having a look at. This was a combination of work between Newcastle and Cambridge University to kind of really focus on identifying the management and treating people with dementia with Lewy bodies and Parkinson's disease dementia. And the idea of the toolkit was really to try and help professionals in secondary care who are doing the assessments and diagnosis, really. So I would encourage you all to kind of have a look at that website and some of the research around the work that they've done with this. So for today, again, this is a very difficult topic to kind of cut down into kind of 30-45 minutes. So today we're really just going to have a look at the cognitive kind of features, the neuropsychiatric and the sleep, and I'm going to leave the autonomic and motor, and we've got information on the website for you to have a look at to kind of support with those, but I guess that's kind of your area of expertise as well. So first of all, just thinking around kind of cognitive, the first treatment really is cholinesterase inhibitors with all dementias, and Parkinson's disease and Lewy body dementia is no different with that. So we've got the three different types of cholinesterase inhibitors. We've got donepezil, rivastigmine, and galantamine. And the choice of what you use is often depending on your experience, administration, dose, titration, and obviously the side effect profile as well. Typically, people tend to opt for donepezil first because it's a once a day dose. So again, if you've got carers or if you've got people that you need to rely on to be able to take their medication, often donepezil is your first port of call. In terms of evidence base, though, rivastigmine has more evidence base in Parkinson's disease dementia, and there's much less evidence for galantamine in Lewy body dementia. Before starting any cholinesterase inhibitor, it's really important to check cardiovascular disease. So again, we don't always do ECGs for people, and certainly through COVID, we haven't been doing ECGs for everyone, but really important to kind of look out for those people who've got orthostatic hypertension, syncope, presyncope, or cardiac arrhythmias, or bradycardia, that's the other thing. And where you're uncertain, have those discussions with the cardiologist should you need to. And with any cholinesterase inhibitors, you're titrating to the maximum dose, and you would continue at this level unless someone had any side effects. The other drug that we often use in dementia is memantine, and you could use this on its own, or you could use it in combination with other cholinesterase inhibitors. Nice guidance at the moment is that memantine is used for moderate to severe, whereas the cholinesterase inhibitors are mild to moderate dementia. But really, it's about the clinical presentation of the person, and also obviously the side effects. So if you've got someone who can't tolerate a cholinesterase inhibitor, then you would be looking for memantine to try and support them with their cognition. So again, you're going to be thinking of kind of the cautions with memantine, particularly with people with a history of seizures or people with any poor renal function. So really important to think of EGFR before you're prescribing this. And also think about kind of how they can enhance some of the other kind of problems and the other tablets that they're taking as well. So when you're starting any of the cholinesterase inhibitors or memantine, really important to kind of assess response, and that will help you kind of decide on whether you're going to continue with the medications or not. So to start with, really important to have a global and behavioural psychiatric baselines of symptoms so that you've documented that. And often that's more than just a cognitive score. You know, an ASAR will only tell you so much. Actually, it's about the behaviour and the history that you get from the patient and their relatives as well. And once you've established someone on a cholinesterase inhibitor or memantine, you're looking at 6 to 12 months to assess the outcome of that at the maximum dose. Some people take longer to respond. So again, it's always individual when you're assessing someone. And again, you want to continue treatment as long as it's positive and there's benefits for the patient to do so. If you decide to withdraw any cholinesterase inhibitors, it's really important to do this gradually, because often you can see a worsening of symptoms as well. And if people don't respond to one cholinesterase inhibitor, we would generally switch to another one and try a different one. So you may try donepezil or rivastigmine first, and then move to a different cholinesterase inhibitor. And I think in terms of when to stop, that's the other discussions that we often have with people, in terms of, because obviously these are neurodegenerative conditions, they're going to get worse over time. So you wouldn't necessarily just stop a cholinesterase inhibitor or memantine because someone's falling below their baseline or their cognitive scores are getting worse. So it's actually, you would keep them on it as long as you felt that it was appropriate to do so, and clinically helpful for that person. In terms of non-cognitive, in terms of non-pharmacological kind of therapies, cognitive stimulation therapy has got a really good evidence base for it. So it's found to help with memory and thinking of people with mild to moderate dementia, and it's recommended by NICE. It's often done in group therapies, and over COVID we've been doing it online, but definitely it's helpful to do it in person, and it's been shown to improve people's quality of life. It's cost effective and value for money, and people do have very good positive outcomes from it and seem to benefit. So at the moment it's recommended for people for mild to moderate dementia, and it's a course of so many sessions per week. So they're normally 45 sessions twice a week over a period of 7 weeks that you would do. And of course the other things that are really important in terms of cognition is about social stimulation and interaction, about exercise, and also the importance of using memory aids as well can kind of support. And I think all kind of services that have looked after people with memory problems over the last year will have seen a rise in the amount of referrals, given that people haven't been socially stimulated or interacting with people. So I think that's had a huge knock-on effect for those people that we've been supporting with memory problems. In terms of neuropsychiatric symptoms, I think it's really important to establish the severity of those symptoms to start with. I think we would never try and treat someone with for any of these symptoms unless they're significant and severe enough, either with the intensity that they're experiencing or the frequency to cause distress to someone. So we often see people with visual hallucinations, and actually there's quite a majority of the population that have visual hallucinations without any kind of mental health problem, and they don't cause them distress and they don't cause them any problems. So certainly we wouldn't be treating those. So I think it is about asking those questions: how frequently does this happen? What is the impact of that happening? And what is the response in terms of the behaviour to those neuropsychiatric symptoms that the person's having? And again, the collateral history is really helpful to establish from informal carers as well. Other factors causing aggravated mood, really important to rule out. So again, physical illness, pain, discomfort, any environmental precipitators, anxiety, depression, all of those things need ruling out before we say that this is definitely due to their dementia. So where we do get people, of course, where they are having significant distress from visual hallucinations or delusions. And I think it's really important that we talk to people about the risks and benefits of using treatment, and particularly using antipsychotics. We often get called to care homes or to GPs or family wanting things being treated, but actually not understanding the risk benefits and the risks around using antipsychotics. So again, it's important if you're starting someone on an antipsychotic, you need to be seeing them regularly. You need to be seeing them quickly afterwards to establish if they've had any sensitivities or any reactions to that. So it is about making sure that you're aware of the significant mortality and morbidity when the use, particularly with dementia and Parkinson's disease. I had a gentleman recently with Parkinson's disease dementia whose GP started him on risperidone, and within a day he could barely move. So again, that was quickly stopped, and we kind of were involved from that point of view. And again, think about what kind of symptoms you're trying to target and how you're going to monitor these, and obviously watch for worsening cognition and any subtle changes or deteriorations in motor functioning as well. In terms of choice of antipsychotic, again, there isn't just one antipsychotic that works better than all the others. It is again about thinking about the individual and the risk benefits and the, again, how you're prescribing, frequency of prescribing. So all of those things come into account. And I think you'd always tend to go for the atypical antipsychotics, such as quetiapine, that has the least kind of side effect profile. So again, you're thinking about what type would suit this person. So quetiapine is often normally the first drug that we would tend to use, and really important to kind of start low and go slow. So you're starting at the lowest possible dose. Sometimes we're doing half doses for people. So it's not uncommon that we've started quetiapine 12.5 for people. And in terms of kind of really slow in terms of the way that you titrate that up and monitoring very closely for any problems or side effects from that. And again, thinking about time limited and when you're going to review it. So it shouldn't be, these drugs aren't drugs that you start and then you don't ever review and they stay on them for life. So again, really important that we have a look. And of course, there's clozapine as well. So clozapine is a very different kind of antipsychotic that's used mostly to treat resistive schizophrenia. But there is evidence based in Parkinson's disease, particularly where people are psychotic. But there's not so much in terms of Lewy body dementia. And again, it's really important that we understand what starting one of these drugs means. So you have to be registered and the pharmacy has to be registered to give clozapine. And there's also a high level of blood monitoring and potentially fatal side effects when using this drug. So don't start it lightly. If you're going to start it, you need to make sure that the person can actually get to have their bloods done regularly, knows what to do if they become unwell. Clozapine can be affected by all sorts of things as well in terms of temperature, drinking, dehydration, lots of other areas. So again, you need to be confident that the person that you're looking after will be able to manage should they become unwell with clozapine. In terms of sleep difficulties, so again, as Tim said, really common for people with Parkinson's disease dementia and dementia in Lewy bodies. And wherever possible, we don't want to be using medications for this. So you would always give important advice on sleep hygiene. So things like, again, routine, nightly routine is really important. What do they do before they go to bed? And having that regular routine for people, cutting down alcohol, cutting down caffeine, but particularly in the afternoons before people go to bed, thinking about temperature, thinking about comfort, thinking about light. All of those things are really important in terms of sleep hygiene, minimizing noise, minimizing distractions, turning off TVs, all of those kind of good sleep hygiene that you would recommend to anyone. So that would always be the first starting point for any sleep difficulties. In terms of REM sleep difficulties, again, you'd be considering, is there anything else going on that could be mimicking this? And again, you'd look for non-pharmacological strategies as your first line. So again, do we want people to be placed on the floor? Would they be more comfortable? Removing dangerous objects around? Do we need to pad things? Do we need to move objects off the bedside table because they keep knocking them off? And often when you talk to people, it's not particularly the person that's struggling with their REM sleep disorder, it's the other half. It's their partner that actually wakes up and is battered or gets a kick from the leg moving. So again, it's thinking about, actually, is there some sleeping arrangements that we can do that actually help this person? Because again, it's the knock-on effect of the carer if they've had very sleepless nights. From a pharmacological point of view, clonazepam is one of the drugs of choice that we would tend to use as well. So again, given 30 minutes before bedtime, but again, being aware of the side effects, which can cause increased risk of falls or worsening cognition. And melatonin as well is another option. But again, with melatonin, I think it's worth, not every GP will be prescribing melatonin. So again, it's being aware that if you start it in clinic, are they actually going to pick up that prescription as well? So we tend to try and steer away from the Z drugs if we can. That you do find that people get very desperate and the GP will start them on, and generally my experience has been they aren't that helpful, so you end up with people taking medications that aren't really having any effect. In terms of autonomic and motor symptoms, I'd just refer you to the management, the Diamond Lewy body trial management structure for that. So there's got some very detailed information on there for you to have a look at. And in terms of support, so support for this group is really vital, because things are changing constantly. And as Tim said, things are deteriorating quite quickly compared to other dementias. I think it's always really important that we kind of focus on the GP and remember that the GP is the first point of call, and they can obviously call in all the other kind of mental health services as well. They're not going to be a specialist in this area, but again, they'll know where to get that specialist advice and support from. So really important that families know that the GP is there. In terms of local mental health services, so they tend to kind of hold quite complex cases with Parkinson's disease dementia and Lewy body dementias. So these can be a variety of people, from memory assessment services to dementia intensive support teams to community mental health teams. So again, think about what's available in your local area, think about who the key people are to speak to and have links with, because it is about who looks after which section. So I've got a gentleman at the moment who's seen a neurologist for his Parkinson's, he's seen a geriatrician to try and help with his cognitive problems, and he's seeing me to help with his behavioural problems. So again, it's how are we all linking together to make sure that we're not all saying go to the other person to make the decisions, but actually we're not also we're following a treatment path and everyone knows what that is and who's doing what. Alzheimer's Society are really helpful. They have a huge amount of website information there, and they also do lots of telephone contact. There's a new service that they're doing in terms of the Connect referrals, so you can refer to people online, and they've also got kind of separate pilot projects running up. So at the minute in Cambridge, there's a project to help reduce to support with people who are going into hospital and to going into residential homes as well. So they will do intensive support for those carers, which is really vital, and we see it makes a huge difference, particularly when people are moving into kind of long-term care. Caring Together is another website that's really helpful. Admiral nurses as well. Not every area has Admiral nurses. Unfortunately, in Cambridge, we don't have Admiral nurses, but again, you might have them in your local area, so worth giving them a ring. And dementia care navigators, again, this is something that not all areas have, but is a way of, again, supporting carers to navigate around the dementia services involving social care, healthcare. So really helpful for carers to use as well. And the other thing I just wanted to mention really is about research. So getting people involved in research can make a huge difference to people in terms of actually the support they get, but also the new things that are going on, and people feel and have very positive effects from research, particularly when they're engaging in a particular study and feel that they can help with a particular study. So at the moment in Cambridgeshire, we've got some research around kind of Alzheimer's and doing different reading therapies and music therapies. So actually the people get an intervention, which is obviously a benefit to them. So, and also the contact that they have with the research team is often very supportive in itself. So again, wherever possible, we'd suggest that you talk about research with anyone that you're seeing, and think about what studies are available, and you use the Alzheimer's UK to kind of guide people in terms of research. Okay, that's it from me.
Alison, thank you very much indeed. So before we go to questions and answers, I'd like to introduce you to Professor Hiroshima Leroy, who's going to talk a little bit about the up and coming Lewy Body Masterclass, where you can dive deeper into this subject and learn much more. So Hira, over to you.
Thanks very much, Dag. I'm just checking my sound is on. Before, I'm going to share my screen, but before I do that, I just wanted to pop something in the chat. Bear with me, and it is the website. Hold on a second here. So I've already put the Diamond Lewy website on there, but also I've put in Lewy Body Society because their information is absolutely superb as well. And just to make about your point on the Admiral Nurse, Alison, Lewy Body Society now has a dedicated Lewy Body Admiral Nurse, Rachel Thompson, and she's absolutely fantastic. And the beauty about her is that she's area agnostic. So she'll take calls from absolutely everywhere, even Ireland, where I am. Although I shouldn't be telling this because she's already quite overwhelmed, but a fantastic resource as well. Okay, so let me just quickly share my screen if I can find my document. Here we go. So it's just to draw people's attention to a new academy that we are going to launch this year. So it's Lewy Body Academy sponsored jointly by Lewy Body Ireland, which is a new charity, and the Lewy Body Society, and of course, the Neurology Academy. And the course is a very similar profile as the other masterclasses. In other words, it's targeted at people working with older adults with these kinds of disorders. So old age psychiatrists, geriatricians, neurologists, specialist trainees, clinical nurse specialists. And again, exactly as Diga said, it's just a deeper dive into the topics that you've been hearing about today. And very much the management will be centered around the Diamond Lewy Toolkit, which you've heard from Alison. And so it'll be teasing apart all those different bits and really ensuring that people come out of that course with a core understanding of how to approach things. Just to make a quick pitch, who's going to be the lecturers on the course? John O'Brien will be one of our lecturers, John Paul Taylor from Newcastle, Joe Kane from Belfast, Sean O'Dwyer, who's a neurologist from Ireland. So we're very much doing a Northern Ireland, UK offer here. Professor Ian McKeith will be speaking at the evening session, which will be the night before. So everybody's very welcome, and some of you may already have put in your expression of interest. We have 25 slots, but if we have a lot of interest, we will run the course again. So that's that. And I think now we are going to go over to Q&A. We've got 4 questions in the chat. So the first is, I think it's more of a comment from Sandeep, basically saying that autonomic dysfunction is fairly common in PSP and DLB, probably more than idiopathic PD. So autonomic dysfunction in any Parkinsonian syndrome is not that helpful in teasing out Parkinsonism. So Tim, would you just comment on the comment?
Yeah, sure. So I think I maybe should have been a bit clearer that you do get autonomic dysfunction, of course, in DLB and Parkinson's disease. But we just clarify, autonomic dysfunction is associated with the alpha-synucleinopathies. So that's Parkinson's disease, MSA, and DLB, but not with the tauopathies. So PSP and C corticobasal syndrome, we don't see autonomic dysfunction. And so I think it's helpful for distinguishing those two broad groups. I think in MSA, I was trying to make the point really, not terribly clearly, but that's one of the prominent early symptoms. So people come to the clinic because of their autonomic symptoms. So yes, you do get them in DLB and PD, but they tend to be later and not quite so prominent, I would say. So I think that's, so thanks for sort of making me clarify that.
Thanks, Tim, that's really clear. So the next question is from Sally, and there's 2 from her. I'll direct this at you, Alison. If assessed initially with an ASR, are we to expect maintenance scores, improvements, or just to rely on reported behavioral aspects or changes when treated for neuropsychiatric and cognitive changes? So that's a big question. A big answer, but go for it, Alison.
Again, I think it's about what are you treating, isn't it? And kind of looking at those. So you would expect anyone with a dementia, their scores are going to deteriorate over a period of time. That's and again, it's very individual in terms of how quickly people would deteriorate and where your starting base is from as well. You might get someone who's scoring particularly low to start with. So again, if you're treating with a cholinesterase inhibitor, you might not expect to see any change in those scores, and that they gradually will deteriorate. But that doesn't necessarily mean that they're not able to cognitively, they're not able to engage in conversations better with their families, they're able to interact better, they're able to recall information. So again, it's thinking about what you're treating. In terms of neuropsychiatric symptoms you would be expecting. So if you're treating hallucinations, you would be with quetiapine, you would be expecting to see a benefit to that. Otherwise, the risk versus benefit of starting medication wouldn't be very helpful. And if those drugs aren't helpful or helping to improve symptoms, then if you're either deciding to change and try a different antipsychotic, or you would be saying that this isn't responding, and that you can only increase to a certain limit, because obviously it starts having effect on other symptoms as well. So the minute, it's always about the balance with symptoms, and it is about which one is more distressing, which one is more difficult. So you don't want to knock someone off their feet because of the behavioral, the symptoms that might have in terms of their mood and their ability to function in other ways. So again, it's always a bit of a trade-off about what the person and their family feel is the most distressing, which isn't always what we consider to be the most important. So we may not, and certainly as dementia progresses, actually the trade-off is often less with motor symptoms actually, and often we end up kind of stopping and reducing the Parkinson's drugs for a more relaxed and settled patient. So is that helpful?
Super, thanks for that. Another question from Sally, and again, this is for you, Alison, just if you can answer briefly. This is a question very much of its time. If patients are not online for advice and support, what do you suggest?
Telephone. Nearly everyone engages with the telephone, and certainly there's loads of people that you can call and have advice through the telephone, so particularly the Alzheimer's Society. Yeah, so use the telephone.
Super. Tim, I'm going to direct the next one to you. At the Alzheimer's Society, we see a lot of people with DLB who are typically referred from local memory services. We see a lot fewer people with PDD though, and I'm curious to know why this might be. Is it because they tend to receive their diagnosis through neurology service, or because it tends to be long after the initial PD diagnosis? Does neurology have much looser links with local dementia support services?
Yeah,
important question.
Yeah, I think it is a good question. And I think it's true. We're, as a neurologist, we are a bit ivory tower, and we do hide ourselves in our clinic, and we're not as community facing as the psychiatry services are. So I think that is probably part of it. I also think, neurologists, you normally have sort of 10, 15 minutes for a follow-up patient to go through all of their Parkinson's symptoms, of which one may be cognition. So you're only really addressing that for a minute or two. So I think psychiatry tend to have longer time with their patients for follow-up. So I think that's part of it as well, that we just, as neurologists, we're more comfortable, or most neurologists are more comfortable with sort of assessing motor function and less comfortable with cognitive problems. That's something we need to address as neurologists. So I suspect there is something in that.
Super. Thanks very much.
And I think that's probably vice versa as well for psychiatrists assessing, motor symptoms as well.
Yeah, that's true.
I'm going to jump over to a question in the chat, actually. Oops, hang on a minute, I've lost it. Bear with me. I've got too many screens going on here. Okay, well, I'll have to come back to that. I've lost my screen.
Is this the quetiapin one? Because I can see it.
It's yeah, please. Yeah, can you answer the quetiapin question? Yeah,
well, what sort of dose of quetiapin do you use, as there is a risk of increasing Parkinson's at high doses? I think, I think Alison sort of answered this, and we say we use very low doses, so the lowest possible dose. I think I really try not to have people on dopaminergic so levodopa and antipsychotics at the same time, because they're just doing the opposite of each other. So my first instinct is always to try and reduce the levodopa and then introduce a sort of small dose of quetiapin. So yeah, 25 would be a reasonable starting dose, but 12.5, as Alison said, would be reasonable to do as well. Do you think that's fair enough, Alison?
Mm-hmm.
Yeah, thanks for that, Tim. And actually just carry on and address the next question, which is rather curious, about GPs increased prescribing rates of risperidone in people with PDD. So that could be a bit of a local issue. And the question is
I think people go through phases with drugs, don't they, a little bit? And what's kind of fashionable and what someone knows and what someone has worked before. I think we all get into that kind of remit of prescribing what what has worked and how it's worked previously. So I think it is about how it's been monitored when it's being used and what the reason is for it to be used, and making sure it's kind of and again, if it's helpful to that person. But the same as kind of Tim, have we looked at all the other areas and all the other medications before we start adding things, is always your first priority with older clients.
I mean, there is a bit of evidence of increased antipsychotic use during the pandemic, which I think does need addressing, so maybe that's part of it.
It might be, but I think generally the advice with Parkinson's is that of all the atypicals, respiratory would be at the bottom of the pile. So just be cautious. That could be a bit of a local issue. All right, how are we doing? We've got 1 more minute, so I'm going to sort of pick here with no favorites. Patients is from Sunday. Patients already on cholinesterase inhibitors, do they need MoCA or cognitive scores? And he's making the point that cholinesterase inhibitors may not improve cognition, but mostly improve alertness and visual hallucinations. Go for it, Alison.
So do we need to be scoring them? Do we need to use them? Is that what they're asking?
Yeah, basically, is cognition an important outcome measure for cholinesterase inhibitors in people?
Is it helpful, I suppose, to the person? It helps to give us as clinicians a help in terms of diagnostic. It's really quite important in terms of when we're making a diagnosis, but actually, is it helpful for the person afterwards? And are you able to get that information in other ways? Often when you've got someone who's struggling with fine motor skills, writing, reading, they're not going to do very well in those areas anyway. So actually you may be able to get that information from a carer rather than and from your own assessment, rather than having to do a cognitive score, so you don't have to.
And also cholinesterase inhibitors often help attention, which isn't terribly well captured by the ASR. So it's, I agree, asking the patients and the relatives is much more useful than the cognitive test, but it can be helpful.
Thank you very much. I think we've run out of time. And as usual, all the interesting questions start coming as we start discussing, but maybe we can address some of these offline if they can be captured. So I think we're going to pass over back to you, Daya, is that right?
Yeah, thank you very much, Ira, for leading that. And yes, we'll try and capture those questions and get them out to individuals. Huge thank you to Tim and Alison for a superb presentation. I think that really helped a lot of people. I think we can see that from the questions that are bouncing in. Fabulous. And also I hope it's whetted your appetite to consider doing the Lewy body masterclass as well, that Ira spoke about. So we now have a short interlude before Robin will start his presentation. So be back in about a minute and a half, people.